Welcome to today's virtual training of adolescent opioid use disorder and treatment with Marc J. Fishman, MD, presented by the Connecticut Women's Consortium. The consortium is a nonprofit organization that is proud to provide cutting-edge continuing education to a wide range of behavioral health professionals. I am now pleased to introduce you to our trainer today. Marc Fishman, MD, is an addiction psychiatrist and leads Maryland Treatment Center / Mountain Manor, a regional behavioral health provider, which offers programs for residential and outpatient SUD and co-occurring treatment for youth and adults. He is a member of the psychiatry faculty at Johns Hopkins University School of Medicine. His academic and research work has focused on addiction pharmacotherapy, models of care for youth, particularly with OUD, and treatment placement and matching strategies. Dr. Fishman served as a co-editor for the most recent editions of the ASAM criteria for the treatment of substance-related disorders. He served as a past president, 2010 to 2012, of the Maryland Society of Addiction Medicine and is a current member of its board. Without further ado, I will now turn it over to our trainer today, Dr. Marc Fishman.
Good afternoon, everyone. Thanks for coming out. As you heard, my name is Marc Fishman, and I'm sitting here in Baltimore, where I do both clinical and research work in addiction treatment. I'm a shrink. I hope you won't hold that against me, and an addiction doc. I have a particular interest in treatment and research on youth treatment, particularly with opioid use disorder, and that's our topic for today. So let's get into it. This is my disclosures. I think the most relevant one is that I've been a consultant for Alkermes, which you may know is the manufacturer of extended release naltrexone, which is a medicine that is used in the treatment of OUD, and we'll be talking about today. I hope that doesn't bias me, but you guys be the judge. And this is what we'll talk about today. I'm going to talk a little bit about the background of the problem. What are some of the grave difficulties with the current opioid crisis in youth? But you guys know that, so I'm not going to spend much time on that. It's terrible, and people are dying, and families are suffering. I'll talk about the background of thinking about medications for OUD, or MAT, medication-assisted treatment, various different words for it, but I'll talk about the background of that as being the aspirational standard of care to be integrated into comprehensive, holistic, multidisciplinary treatment. But that there are plenty of barriers that I'm sure you know only too well that hinder success for young people at many stages of the OUD treatment cascade. And then we'll talk about potential new approaches and potential solutions to those barriers. One of the focuses will be to describe some work that my group has done with an intervention that we've been refining over several years that we call the Youth Opioid Recovery Support Model, or YORS. And the point won't be necessarily to say that everybody ought to do that. We are lucky enough to have some additional research grant funding from the National Institute on Drug Abuse, and not everybody has that, and it's not necessarily a full package implementation that I'll be advocating, but rather to describe some of its elements that don't need the whole package, that don't need extra funding, but are useful to hear about as potentially innovative approaches in trying to think in a developmentally informed way about the treatment of adolescents and young adults, and thinking about changing up usual adult-oriented care to try to get better results. Also, we'll want to talk about other innovative models that are out there, one being integration of OUD treatment into primary care. Talk about the adoption of telehealth, which I have to imagine those of you who are clinicians have had plenty of experience. We've all been thrown into the deep end of the pool over the last 2 years of this crazy pandemic and had to learn how to use that, and lots of interesting ways in which that becomes a potential enhancement of youth care, and talk just a little bit about the possibilities of young adult specific recovery housing. And then throughout, we'll use clinical illustrations and vignettes to be able to give us a picture of the material. And then, of course, let's try to have a discussion. We may be too big a group to actually shout out, but throw things into the text as we go along. I'll try to keep an eye on it, and then we'll save time at the end for lots of Q&A. An overview, kind of the bottom line of the whole story is these bullet points here. We think of OUD, or I'd like to think of OUD, as along the continuum of the broader disorder of SUD, including non-opioid substances, right? We think of substance use disorder as a whole, and OUD is an advanced, more malignant of that continuum. And as we know, SUD in general usually begins in adolescence, right? In the middle to late second decade of life, and with peak prevalence across the lifespan at the end of the second decade of life and beginning of the third decade of life. So what happens is typically that young people begin problems with loss of control of substances significantly before they're introduced to opioids. And for young people, that's what? Nicotine, alcohol, cannabis. And so, as I'll talk about just a little bit, there's a prevention message there in terms of preventing OUD by intervening in earlier non-OUDs. But I think that conceptual frame is very important. We want to not just wait till things get to that very advanced malignant form. Now, adolescents are early in their trajectory towards opiates, but young adults, that is, 18 to 24, 18 to 26, are disproportionately affected by the opioid epidemic. In the demographic population, there are more absolute numbers of older adults who use street opioids, but per capita, young adults lead the charge among all components of the lifespan, and that's both for prescription opioids and for heroin. We know that medications for OUD are the way to go. I hope that's old news. If it isn't, we can talk more about that, but there's pretty convincing evidence that the tools that we know are effective in adults can be translated into use in adolescents and young adults. But unfortunately, that message has poor dissemination and poor uptake. There are problems with treatment. There's misinformation out there. There's some prejudice against the use of these tools. And implementing those tools is not trivial. Tried it, no, a number of barriers, and we'll spend most of our time today talking about those barriers and how to overcome them. Many of those problems stem from the developmental vulnerabilities that we know that youth have. We'll talk about that. And because of that, presumably, although MOUD and other forms of OUD treatment are effective, those treatments have worse outcomes in young people than they do in older adults. Good outcomes, but not good enough, and not as good as in older adults. And that comes as no surprise when we think about those developmental vulnerabilities and the difficulties we have in engaging young people and in retaining young people. And so what we aspire to then is, can we find improved developmentally informed developmental strategies that specifically target engagement, retention, and medication adherence in adolescents and young adults that could help us improve those outcomes to make them better. And then one of my examples there that will illustrate some of these developmentally informed components is youth opioid recovery support intervention that we've been working on. And I'll tell you a little bit about that, show you some clinical illustrations and show you some outcome data. And then we can talk about how you can break down perhaps some of those components to use in your own practice settings. Just the prevention method, to reiterate, there's this developmental disorder of pediatric onset addiction. I like that phrase, to think about it as developmental. And we know that the most youth who do develop trouble with opioids do first get loss of control with another SUD with non-opioid substances. And so earlier onset is associated with worse outcomes. Earlier intervention is associated with better outcomes. So we need to do something about that. And unfortunately, the current cultural trope, which is that cannabis is not a drug, everybody drinks, it's not such a big deal. You guys know that that's not true, but the whole world doesn't necessarily. And so just a plug for that prevention advocacy that we need. We're not going to just treat our way out of this epidemic. We have to have a concerted effort for prevention. And part of that prevention is addressing SUD before it gets to that so-called malignant stage that we call OUD. A word about MOUD. I'm not going to spend a lot of time talking about the details of the different medicines. If there are questions about that later, because people want to get to those specifics, we can certainly do that. But when we talk about MOUD, we know that there are 3 FDA-approved medicines: methadone, buprenorphine, and naltrexone. Naltrexone effective as its extended-release injectable form. Methadone, while effective for adolescents, is hard to implement for adolescents. There are few to none adolescent-specific methadone programs. Certainly, young adults can enroll in adult methadone programs, but they often don't fit in well. When they do fit in well, it's a very effective and good treatment. But buprenorphine and extended-release naltrexone, and now we have extended-release buprenorphine as well as a long-acting injectable form of buprenorphine, have become pretty much the standard of care, or should become the standard of care in most community-serving specialty SUD treatments that are youth-serving. And just a review of the research we have. You guys know the 60, 70 years of very solid research that we have for adults using the various MATs, MOUDs. Research in young is less available, and not as much work has been done, but a amount of work has been done. And that work, in summary, shows us that buprenorphine is effective in the youth population. But as I said before, the treatment outcomes are not as good as for adults, linking that to developmental vulnerabilities and problems with retention and adherence. In terms of duration of treatment, just as in adults, it looks like longer durations of treatment is better. We don't have some magic bright red line about what the right amount of time is. We don't have that for adults. We don't have that for youth, but in general, longer is better. That, of course, doesn't mean forever. You hear this from patients all the time and their families. Do I have to be on this medicine forever? No, I didn't say that. Let's just talk about getting you on the medicine. Later, we can talk about getting it off, and that's something we can talk about if that's of interest to people. But one important point is that there is absolutely no evidence for a predetermined or arbitrary time limitation. And this comes up at various places in the country, specifically with authorization protocols for insurance, perhaps Medicaid and other insurance companies that say, well, yes, you can get authorized for this treatment, but only for 6 months, only for 12 months, only for 3.5 days. That's an exaggeration. But the idea is there is no evidence for that, except that it's cheaper and people want to save money, but it is less effective. There is no reason to suppose that we should impose time limitations. The time and duration of treatment should be customized on an individual clinical basis. The information available for extended release naltrexone is quite promising, but there isn't as much. I said that there's not as much research done on in youth as in adults. There's even less research done in extended release naltrexone. But what there is leads to promising results and an emerging clinical consensus that it's effective and safe. But again, more research needed. But there's no reason to suppose so far that the clear evidence from adults doesn't translate. Now, that wasn't obvious as we began this work decades ago. We are certainly appropriately concerned about use of various medications in young people, because young people's bodies and minds and brains and spirits are not exactly the same as adults. So we want to look for, are there safety concerns? We want to look for, are there limitations to efficacy and effectiveness? And whereas we don't have enough research yet, or as much research as we'd like, the good news is there is absolutely no signal so far in the research and clinical experience that's been done that there are particular safety or efficacy problems based on age. That's not to say these medicines don't have side effects, right? Every medicine, even a Tylenol, can have side effects. I'm not claiming different than that. But there is nothing about giving these medicines to young people that we've found so far that leads us to believe it's a bad idea or unsafe or ineffective because they are young. And that's good news. So MOUD or MAT should be first line. It should be the standard of care. Some people have talked about using it as second line or based on failing other treatments first. There is no evidence to suggest that a fail first approach is warranted. And that's because the other treatments that don't include MOUD are very much less effective. Furthermore, waiting for a failure can be incredibly costly and catastrophic. Remember, a treatment failure with opioid addiction can lead to an overdose and maybe a fatal overdose. That seems a high cost to pay for figuring out whether it's time to move to the next kind of treatment. So MOUD, standard of care, and first line. But the problem is, or one of the problems is, that despite that clear research message, the dissemination of that has been slow in many parts of the country, and there's been poor uptake. And I just want to show you two research examples of that. On the left is work from 2018 by Scott Hadland's group up in Boston. This is Medicaid claims across, I think, 17 states. It's a very big number of several thousand total youth that were looked at here. And the first thing to note is in the graph that you're comparing those youth that received medication versus those that received counseling or other behavioral health services, but without medication. And this is a graph of retention across a year. And you can see that those that received medication are retained better than those that don't receive medication. And the good news is you can have your cake and eat it too. There are some people who might argue if I give them medicine, they won't get the needed behavioral health services that will be enduringly powerful and impactful, when in fact, those that are getting medication are retained more in behavioral health services, counseling, therapy, and the like, than those that don't get medication. So again, confirmation of the effectiveness and the positive impact. But the problem in uptake is that only 26% of this group of youth, several thousand youth, received any medication. And those under 18 years, never mind 26%, it was only 5%. So we do poorly for young adults, we do worser for adolescents. On the right, we have another study by Mintz from 2020. This looked at a big insurance claims data set. There were more commercial insurance. I include it because we also want to look at the commercial insurance side of things. And the thing to notice is that if you look at psychosocial treatment on the left half of that graph, 6-month retention was low across these three different components of the lifespan. You see it's 12 to 17, 18 to 20, 26 to 64. So when treatment is given without MOUD, in this case, buprenorphine was the MOUD that was looked at, rates are low. With buprenorphine, rates are much higher across all three segments of the lifespan. Of course, they are lower in adolescents and young adults than they are in adults, as we said, worse out. And the uptake is across the top in these percentages here. The percent receiving MOUD are very much lower in adolescents than they are in adults. So there's a big problem in uptake. So what does that mean? That means we know the medicines are effective. We know people aren't using the medicines. All we need to do is write more prescriptions, right? And we've got a cure for opioid addiction. Everybody can go home. We good? Of course not. If only it were that simple. And there are many other ingredients that we need in addition to MOUD. I'm trying to make the point that MOUD is necessary but not sufficient. But even with MOUD, medicine doesn't work that well in the bottle. People got to take it. People got to show up for treatment. People got to engage. And that is not trivial in any target age group, but it is particularly problematic in this group of young people. So let's go from the research to a kind of a more personal clinical vignette. This is kind of a person, not a real person, but I'm sure you've all met him or her. 18-year-old or 20-year-old or 24-year-old young man or young woman began smoking cannabis at age 14, pretty typical. For some of our folks, it's younger, of course. Began using prescription opioids at 17, progressed to daily use of prescription opioids, including full physiological dependence and withdrawal within 8 months of first taking a Percocet at a party. Onset of nasal heroin a year later at age 18, and then 6 months later injecting street heroin. Now, that's a pretty typical story. Not everybody has that kind of story, but one thing that's illustrative of is the condensed time frame, right? We think of OUD as this particularly malignant form of SUD, and one of the illustrations of that is that it accelerates in its course. First Percocet at a party to injection heroin daily within 18 months. Wow. You wouldn't see that in alcohol. First beer to a half a handle of vodka 18 months later. That takes decades. Not that I'm saying alcohol is trivial. Alcohol is obviously quite dangerous for many people, but it's important to see how OUD has a typical course, and I'm sure you've seen this. So this person's had some treatment before he comes and sees us. He's had 3 episodes of residential treatment, including detox. He's lucky. In some states you can get that, in other states you can't. But he's had that opportunity. Unfortunately, hasn't worked out so well for him. 2 of those he left prematurely against medical advice. 1 he completed to graduation, but despite the close coordination and recommendation for continuing care outpatient, he never showed up at an intake. He's had 1 outpatient-initiated course of buprenorphine treatment. That also didn't go so well. He met a bupe doctor who said, "Oh, you have opioid use disorder? Well, here's a month's worth of buprenorphine and 4 refills and have a nice life. Hope things go well." Not exactly a poster of optimum buprenorphine treatment. And he took that erratically, sold half of it, continued to inject heroin on top of it. I know you know the drill. And so that didn't go so well. So here he comes back to me, to you, whatever, and he says, "You know what? My life is a mess. I'm in 7 kinds of crisis." And you know what those look like. He's been thrown out by his parents, or he's about to be thrown out by his parents. He's in trouble with his probation officer. He's been fired from his job. His girlfriend's broken up with, all of the stuff all at once. And he says, I know I haven't necessarily done this the right way in the past. I know I didn't follow instructions. I can do better. This time I for realsies mean it. I'll stand upside down naked in the rain, Dr. Fishman, if you need me to do. Are we good? Oh, and by the way, I'm kind of in a hurry. And there's this party I want to go to Saturday night. And I need to be texting with my girlfriend. I don't really have time for the intake right now because there's this important text I need to send. Oh, and I need my homie about this other issue. And, oh, did I tell you, I can't take Suboxone. I can only take Subutex. Oh, or did I tell you I have this terrible anxiety problem and only Xanax works? Oh, but you can't talk to my Xanax doctor. You can't talk to my mother. But other than that, I'm an open book. Let's get started. I don't mean to trivialize the severe suffering of a guy. I mean, this is a serious thing. He could have a horribly devastating outcome. But I just joke a little bit about it to say, what in tarnation are we going to do? How are we going to make this go better and not just have it be more revolving door detox? And this guy I've seen 3 times, guys or girls like him that I've seen 10 times. And at what point can we make progress over that? So let's talk about some possibilities about approaches to this. And I just want to put out some thought experiments or some hypothetical questions. And I'm going to focus throughout our conversation today on an element that I think is really important as a critical add-on to youth treatment. And that's my advocacy, family involvement. Not an easy thing to do, in my view, an important thing to do. So let me just give you some puzzles here. He says, listen, my parents don't get it. They don't think BUP is real recovery. It's trading one addiction for another. It's just, the usual stuff. And they think I sell it. I swear I never sold it. Well, except for that other time and that time and the other time, but mostly I didn't sell. Okay, right. But they don't get this. They do nothing but nag me. You can't talk to them. What do I do? What do you do? I mean, should I say, that's nuts. This is only going to work if I involve your parents, whether involving the parents is helping them understand why BUP might be a good idea, or whether it's ratting on him to try to in his view, ratting, not in my view, but in his view, ratting on him in order to help them do supervision. Whatever the motivation is, whatever the content of the communication is, do I just ignore him because I know better and I call the parents anyway? And I set this up as a bit of a straw man. And my view on this is it's a false dichotomy. It's the wrong question. This kind of question that often gets us in trouble with trying to think about family intervention and family involvement. Like it has to be either or, and like it has to be a unilateral backdoor communication without his cooperation. In fact, we can have it both ways, I think. We can get to yes. And the goal is that we can figure out how to bring him into the conversation in a way that makes involving the parents more palatable. And if he can get invested in it, we're more likely to be more successful with him and more successful with the parents. And who knows, if we're super lucky, lay some groundwork for them doing better communication in the future when I'm long gone. What about if I say to him, instead of, you can't tell me, he told me you can't tell me what to do, and I say back, well, you can't tell me what to do. I'm called, no, instead of saying that, what if I say, well, gosh, you want to be on buprenorphine. They don't think you should be on buprenorphine because they don't think it's real recovery. What if I could help run interference for you and help you figure out this puzzle? They want to throw you out on your behind because you lied and stole the car and whatever other horrible things and never want to see you again. At least that's your view. What if I could run interference and help with reconciliation and you could give something to get something? Oh, I can't talk to them. That's impossible. They don't understand all that. Well, I get that, but what if they were a third party, et cetera, right? So if I can figure out a way to earn some points by showing him that maybe I can get the parents to calm down a little bit, stop yelling, and maybe think about potential negotiations for solutions. All right, so 6 days later, and this is in residential, this could be an outpatient, and we could translate the circumstances into an outpatient scenario. But let's say 6 days after admission, remember, there's this big party coming up, and he says, this place stinks, I'm out of here. I know I promised, but I can't take it. I hate it. I can't be cooped up. You got the French fries are awful, whatever. You guys don't understand me. I'm gone, right? And it's 11 o'clock on Saturday night, and he's out the door. And he won't take a prescription. He won't take a appointment for a follow-up. And I don't know where he's going. Call the parents, yes or no. And situation one, there was no emergency. I had some time. I'm at the beginning of a engagement relationship to try to work on alliance, and getting to yes, thinking I got days, weeks, who knows. Now it's 11 o'clock Saturday night and he could overdose tonight. And so my thinking is that this is more urgent. Still, there's some controversy here. If he's not given me, let's say he's over 18, he's not given me consent, I've got to decide, and this is everybody's individual clinical judgment, what the threshold is for imminent harm and dangerousness. That's your personal decision. And you need more details about the clinical situation and the family in the particular case. I've only given you, 2 sentences. And so that's not fair. But I'll tell you where my bias is. I make that call. Not everybody agrees with me, but I think that one filter to think about that is, let's say it was your kid. Would you want that call? My answer is, I want the call. But again, I get that it's not a trivial question, and it's something we have to struggle with, and I throw it out there as an illustration of some of the tensions that we face. So remember, I've been talking about youth vulnerability. What are some of those features, right? What are some of the barriers we face? Well, they're invincible. They've got 7 kinds of different immaturity. They're very low, typically, along the stages of change. They walk in the door at best contemplative and usually pre-contemplative or pre-contemplative. Treatment has very little appeal, right? In general, we ought to be clear about a fair self-criticism of us as treatment providers. We haven't done enough to make treatment appealing to people, but especially not young adults who can think of a lot of things they'd rather be doing than sitting around in group. Another problem is that for younger people, adolescents and young adults, they don't have as many road miles on them as older adults. So the consequences of their OUD is less salient to them. They haven't lost 6 marriages, 7 mortgages, spent 12 years in prison, had 7 soft tissue infections, been homeless, or at least most of them haven't. Some have, but most of them haven't. And so that doesn't make as much sense to them. Not that folks with addiction are typically avoiding anyway, right? They're more reward seeking than they are consequence avoiding, but it's certainly not there's avoiding if they've had fewer consequences. And there's a very strong salience to them of the burdens of treatment. As I said before, there's lots of things they'd rather be doing, but treatment's very, very low on the list. Another issue is that the family leverage is very variable, and we'll talk about this. By the time families get to you and me, they're up to their ears in alligators. They've tried different stuff. They say, nothing works. I can't do this. You fix them. See you in a month. And that's hard to work with, right? They also have a great deal of pushback against their subjective sense of the intrusiveness of their parents and the sense that everybody wants to see them as being dependent on adults and that their parents are restrictive to them. And that's developmentally normative. That's part of what we want to have happen as people start to grow up. It happens to teenagers that don't have addiction, which is, I'm all grown up. You can't tell me what to do. It's none of my parents' business. I got this. Well, on the other hand, although that's normative, we know it's not very helpful for this group of young people that don't really got this. So how do we parse that? And then you can't emphasize enough that there's tons of psychiatric comorbidity, mood disorders, anxiety, PTSD, whatever. And we don't really have enough time to talk a lot about that, but it's important. Now, here's just some research that sends home the point of worse outcomes. On the left is a secondary from the XBOT study. That's a famous study in medication treatment for opioid use disorder you may have heard of. It was in adults 18 and over. It compared extended release naltrexone versus buprenorphine and showed that if you got onto either medicine, both are about as effective, but it's harder to get onto extended release naltrexone or easier to get onto buprenorphine. That's something you guys probably know about. We did a secondary analysis in which we divided the populations up, not into which medicine they were on, but into age groups, young adults versus older adults. And we were not shocked, or you shouldn't be shocked, to see that young adults didn't do as well. So at the end of 6 months, the retention in the young adults was 34%. The non-relapse was 34%, and the non-relapse in the older adults was 49%. Flip the reciprocal, right? That means 51% of adults relapsed, but 66% of the young adults relapsed. So still a good result, but it's not as good as we aspire to and not as good as we can achieve with older adults. So again, an illustration that something is missing, and I think it's this developmental barrier. On the right is the same kind of example, but in a big Medicaid claims data set, looking at the difference in retention across 6 months. And again, It's lowest in adolescents, highest in older adults, and intermediate in young adults. Again, making the same point. Here's some clinical treatment data from a case series that we published several years ago, in which we tried to make the case that MOUD treatment outside of boutique research, but in the usual care community clinic for Medicaid pennies, was feasible. So here's a group of 65 young adults in a specialty IOP for OUD. And it's a bit of a cherry-picked population. So take this with a grain of salt. These are folks who'd gone through residential treatment and completed, who'd accepted a referral, who'd initiated onto MOUD, either XR-NTX or buprenorphine, who'd accepted a referral for IOP and said, yes, I'm willing to go 3 times a week, and I know the rules, and I promise I'll do it. And not only promised to do it, these are the ones that showed up. So it's a very select group of people downstream on the cascade of care. But given that, we had 40% retention at 6 months and no difference between the two medicines for Medicaid pennies. So we were pleased with that, although 40% is not as good as we'd like. Again, not as good as the typical results for adults, perhaps. And we know that this is not the experience that we'd see further upstream on the cascade of care, right? So here's a group of 380 some youth at presentation to residential treatment. This is more like the guy I showed you before who comes in crisis. And these are folks that came through the residential treatment center, scattered from different areas in central Maryland. And first of all, it's interesting to see what kinds of treatment they're able to accept. So a third of them say, I'll be on extended release naltrexone. This is not randomized. This is by clinical choice, patient choice. A third of them say, I'll take buprenorphine. But fully a third, even more than a third, say, I don't want your stinking medicines, despite that being our standard of care, despite our this is what you ought to do, despite our telling their families, this is what we hope your kid will do. Fully a third of them say, not going to do it. But 2/3 do. That's good news. And so this is a group of people that get started in inpatient treatment on MOUD, but then what happens to them? We give them referrals to outpatient treatment, IOP, OP, whatever. We include in that plans for continuation of their medicine, but rates of retention are, as you might expect, alarmingly low. Over the next 6 months, among the group that elected to get extended release naltrexone, the mean number of doses was only 1.3, right? That's out of 6 monthly doses. 2% of them got all 6 doses. And it wasn't much better for buprenorphine. Only 57 days out of the 180 days in the next 6 months were buprenorphine days. So as good as we might do in that introduction and initiation and engagement to care, over the next bit of, if you don't mind the editorial, it stinks. And dropout is the rule, and retention and continued engagement is hard. So again, the puzzle, this is upstream, right? These aren't people who have shown up at outpatient treatment. That group would do better. But going upstream in the cascade of care, looking at all comers, which is the appropriate, I think, denominator, because you got to see how can we cast a wide net. And so that's part of the puzzle. So here is then one possible partial solution to that puzzle, a work in progress. And this is the intervention I mentioned before that we've been noodling with, the Youth Opioid Recovery Support Intervention. And it's a work in progress that we've been working on for a while and have done some research on and some clinical development on. And it has these 4 components. And I'll describe them, but as we currently have it now, we've bundled these four components together, kind of a kitchen sink or shotgun approach, do everything and see what sticks. But as I say, we have the luxury of some grant money. Not everybody has that. And so I think that one of the things I want you to look at, or the perspective I'd like you to take, is that any of these components probably have value, are probably worth looking at. Even pieces, not even the whole component, but pieces of it probably have value. We haven't done the work to study what they are individually. We're only so far studying the package, but I think that each of them have potential. So let me describe what they are. One is assertive outreach. That means chasing people, not waiting passively for them to come to clinic. Family involvement means involving a treatment significant other. That's typically a parental caretaker, but we've also extended that to boyfriend, girlfriend, mentor, sponsor, grandma, aunt, and other kinds of things. Our success has mostly been with parents, and of that, I guess you can imagine that it's moms more than dads, I'm sorry to say. But anyway, cast a wide net. Home delivery of medication, in which we are starting people on extended release MOUD. When we first started this, the only one that was approved was extended release naltrexone, but now we have extended release buprenorphine, brand name Sublocade. So start one, we don't care which, choose a medicine, get monthly injections, and we deliver it to you at your home. So again, reducing the barrier of having to come in, if that's helpful. And then lastly, contingency management. That is giving people incentives for receipt of medication. And we bundle all these things together, but any of these things, if you could figure out a way to implement them, and I don't say that lightly, that is not trivial. These things, take a lot of effort. They're a heavy lift. But if you can do any of them or do pieces of them or think about how to implement them, I would argue that they have advantages for overcoming some of these developmental barriers that we're talking about. So let's talk through them in some detail. The idea of assertive treatment is not new. Those of you who've worked in mental health know about assertive community treatment for chronic and persistent mental illness like schizophrenia. That's a well understood and practiced model across the world. We know about directly observed delivery of medications for tuberculosis or HIV. That's a well-established assertive intervention. And so this is a thing that where you have a chronic illness in a hard-to-reach, chaotic population in which medication adherence is a major barrier, and you're lucky enough to have a medication, which is not true of all such conditions, but thank goodness for OUD, we got good medications, and for schizophrenia, HIV, and TB, we got good medications. So this is a model that's been time-tested. Why not do it in OUD? The family engagement piece, I think, is one of the things that it might be easiest for people to do. Again, it requires the bandwidth of getting staff trained up and enthusiastic and freeing up enough time to do it, because it's not trivial, but it doesn't necessarily require a whole lot of extra funding. And why don't we do that in routine care? Maybe I'm wrong. Maybe you guys at your home settings do it, but most SUD providers do not. We give lip service to addiction is a family disease, but it's not easy for most providers to really do a lot about that. Some places have standard family education programs, and that's huge and that's important. But the kind of ongoing family partnership that we might aspire to is hard to do, and I think not common. And why? Well, we already talked about the normative pushback that young adults might have against their sense of family being over-restrictive. But it's also that people aren't trained and people are uncomfortable, and it's a hard thing to do, and there's lots of negotiation to do, and it's already hard enough working with the patient, and then you got to work with their mom, and it's divorced, and then there's a dad, and then there's the social worker from the social services agency, and it's a lot. Our field has put a lot of emphasis on internal transformation and understanding and insight. And not that that's bad, but if you guys have ever met a kid and a teenager, That might not be the way that most behavioral change begins, by a bolt of lightning and the scales falling from their eyes and an epiphany transformation moment, right? Behavioral change often happens with external leverage first. And so we need to put that in our repertoire more, I think. When we talk about families in our field, there's often this preoccupying focus, and that's an important concept, and certainly lots of families are enabling, but you know what the families hear when you say when they hear the words enabling. They hear, whether, I'm not saying you mean it when you say it, that's not your intention, but those words mean to families, this is your fault. And that's not a great welcoming start to a collaborative relationship. It just doesn't go anywhere. Whether it's true or not, it doesn't go anywhere most of the time. And then lastly, I think we've been over rigid in our concerns in this field with confidentiality, which is not to trivialize confidentiality as a bedrock treatment we do, really a critical principle. But I think we've been over rigid in our application of it. And one cartoon illustration of that, right, is the classic conundrum that I'm sure you've heard, where mom is bringing the kid into treatment, outpatient, inpatient, whatever. She's waiting in the lobby, having dropped the kid off. She's in the parking lot, whatever. She's paying for the treatment. She knows the story. She calls or she knocks on the door and she wants to talk to the counselor. And what does she get told? We can neither affirm nor deny that a person by that name is receiving treatment at this institution. If you would like to talk to our lawyers between the hours of 9 and 5, please call this number, 1-800-SHUT-UP, right? And I'm being silly, but it is a little bit of the experience that a lot of parents relate, even if it's an exaggeration. And so the question is, can we do better than that? And I think the answer is yes, we can, while still preserving our core principles of why confidentiality is important, but just with more finesse. And so let's talk a little bit about the rationale for family treatment. Both families and youth don't really mostly know how to do treatment. We take it for granted, you know, that it's obvious, this is how this works. But to outsiders, it's very mysterious. What is it you guys do? What is my role? What's the recipe? How do I make this go? If it doesn't go right, what am I supposed to do to try to right the ship? And if we can be explicit about that, we do better. What's the rule book? What's the expectation? Mom, what are you supposed to do? Kid, what are you supposed to do? I think we all would recognize and agree that families mostly have some core competence and some natural leverage points. Not every family. There are some families that are so toxic that we really need to get the kid out, but those are the exception. Most families have something. And by the way, these are the families they have. Well, the families are going to be there long after we're gone, so we might as well try. But mostly, I don't mean that as a message of desperation. I mean that as a message of enthusiastic and optimistic encouragement. Most families have stuff. Can we do that stuff? And as I was hinting before, I think that we can have it both ways. I think that we can encourage emerging youth autonomy and self-efficacy, which we certainly want, but also empower families at the same time if we work at that negotiating process. And as I said before, medicine's good, but it's not going to be the whole thing. And I sometimes joke with the families, yes, this medicine is great. It's a miracle of modern biology, but you're still going to have to parent this difficult young person. How can I help you do that? Whether it's about the OUD or it's about the 27 other difficulties in life that this person has. So our family engagement elements, we call it the family framework, but whatever, family involvement, key elements that you could pick and choose from. One is family education. You might be surprised, or maybe you won't be surprised, how much families don't know about OUD. So how does this work? How does withdrawal work? How do the medicines work? What's their rationale? And what are the roles that family will have? How will you guys support attendance and treatment progress? And let's negotiate all this now and upfront in a three-way treatment plan. And let's get everybody on board in one room, debating it, saying why they agree and why they don't, what they propose, what they can compromise on, and sign it in a written document. Not that it has any legal power, but the idea is now you've got something memorialized that you can come back to. And you say to the kid, well, if you, God forbid, something goes wrong, and this is the backup or rescue plan. God forbid something goes wrong. And I know you think like you've got this in all and things are going to go right, and I hope that's true. But just in case, humor me. If something doesn't go well, what would you like mom to do to help you? Mom, in your family, what's the way to deal with stuff that doesn't go right? And if he doesn't show up, if he has a positive urine, if he misses a dose of medicine, whatever, what do you want to do about it? And how would your family best manage that? And let's negotiate that and write it down now, while everybody's got a brief nanosecond of high motivation before people are hiding relapse and lying and keeping secrets from each other. Let's have it all up front, get the releases signed, get agreements on who's what and who gets to look at the urines and what I'm supposed to talk to mom about. And mom, you're going to have to trust me. I'm going to spare you a lot of the gory details. Young man, young woman, I'm not going to tell mom everything. This is your private treatment. But if I think you're in trouble, I'm going to push the panic button and call the cavalry. And you're going to thank me afterwards, I hope. But you guys are both going to have to trust me. I've done this before. And if you don't like the way it goes, you can always fire me. And that kind of pre-negotiation helps a lot. And then trying to keep them involved as much as you can every step of the way. Now, that's not easy. Families are busy. Families are working 2 jobs. Families have other treatments, other kids. Families face transportation barriers to make these meetings. By the way, telehealth, as I mentioned before, might be a big help there. So our best intentions are not always met, but people are usually quite appreciative of this kind of sense of collaborative planning and mutual negotiation. And every time that we're able to keep it up, we seem to get good results. Now, a lot of times we can't keep it up and we lose the kid or we lose the family or we lose both. But when these negotiations are able to continue, we find that even if things aren't in a unilinear recovery trajectory, you get into treatment and all is well is not the case. It's 3 steps forward and 2 steps back. There is lots of relapse and trying to recover re-engagement post-relapse. But if you lay the groundwork for that, that seems to go well, getting people back into care when they stumble and getting them back up. Work needs to be done for a lot of families on these kinds of things. This is standard parenting work. It's very hard, but it's surprising how little of these families know how to do. As I say, they're embattled up to their ears in alligators. Everything's a crisis. They sway between don't ask, don't tell, I don't want to hear about it, versus the nuclear option, I'm going to throw you out and kill you and cut your head off and I never want to see you again. And there's nothing in between with kind of consistent parenting. So teaching them to pick their battles. I can't tell you how many times I've had to have the conversation. Well, this week's priority, is it going to be he never cleans his room or he's continuing to inject fentanyl? I don't know. You choose. I'm, again, exaggerating, but not by much. So you got to help them with that. You got to remind them about negotiation. You got to give to get. Why should I have to reward him to do the right thing? Well, I don't know. How's it going for you without that? Maybe give it a try. And they tend to have more juice than they realize. Well, I don't have money to be able to buy him a new car just because he didn't use last week. Right now, that's not what I'm saying. What is it you're already doing in your family? What are the kinds of things that bring you together as a family? You know what he or she likes. Is it leisure activities together? Is it special meals? Is it the cigarette money you're already giving them? Is it use of the family car? Is it, what is it? Whatever it is you do in your family, Keep doing it, but now link it to treatment progress. Now make it explicit that these are the rewards of clean living. How can we help you implement that and learn the principles of standard operant conditioning? Think about this as a mouse running a maze for the cheese. How can we help you identify the right cheeses? Not asking you to be rich, just asking you what cheese you got in your refrigerator. And keep your eye on the prize. This is the long game, right? Parents, of course, want you to fix them tonight, tomorrow, next week. But the big picture here, long game, marathon, not a sprint, right? I know we had a bad week. Let's keep at it. And that kind of optimism and encouragement is very helpful, because families can learn then how to manage the kid as well. So it's about the things that they can keep doing on their own if they can learn these skills, even when we're not in the room. So then I told you about this home delivery, where we go to the home with a nurse and a therapist and we give them the shot. Told you about giving them contingency management incentives for receipt of the doses. You may know that contingency management has been best studied in SUD as incentive prizes for negative urines. So this is a little different. This is for receipt of medication, which is not quite as well studied. But our thought was that we would focus this intervention on delivery and consummation of the receipt of medication. And the reason for that is, well, so far, the use of MOUD is probably the single most effective thing we know how to do, but we also know it's not the only thing. So we don't mean to exclusively say it's the only important thing, but we emphasize it in part because it's effective, but also because it's practical and understandable and implementable. And it has to do with this paradigm of utilization of medical care in a family context that I think parents can wrap their heads around. As I said before, for most outsiders, SUD treatment is a bit of a mystery. They don't know the secret handshake and what it is we do in group, hold hands and talk about feelings and what's all that. But people know what it's like to have a sick kid, and that like a 4-year-old with an earache and a fever that doesn't want to take the icky. Moms have done that drill before. That's Mom 101. Kids not themselves, they're truculent and distressed. They don't know how to get good care. They don't want the shot or the medicine. Mom, step up. And it's not trivial because, right, a 4-year-old that you can hold in a basket, hold and squirt the medicine is different than a 19-year-old who weighs 250 pounds and doesn't want the shot. Yeah, it's different. But the conceptual framework is similar. A sick person who's not themselves, who doesn't know how to utilize medical care, how can we help them? And so that's why the emphasis on medicine is the thin edge of the wedge, because it's a good starting place as a handhold or foothold to other kinds of stuff. At least I think that's my theory. So anyway, here's our poster child. He's a 21-year-old man. Let's say he's the same 18-year-old that we talked about before, and he's been in and out of detox over the past few years. Initial doses of extended release naltrexone. But let's say he's never come back for his second dose despite the appointments, or let's say he's gotten the 1.3 average doses out of 6 months, that our other studies showed. So this time he gets the yours intervention, and grandma is going to be the significant other, and he lives with grandma. And so it's a month later after discharge from residential care, and we come with the knock, yours team here, time for your dose. Well, on second thought, change my mind. I don't really want the medicine. No thanks. And I don't know, I can't read his mind, but I don't know if he's decided that he doesn't want the medicine because he thinks he's fixed and he's committed to abstinence without medicines and he doesn't think he needs our stinking shot, or whether he doesn't want the medicine because he's already started to use, planning to start to use next week, and doesn't want to have opioid blockade. But I don't know, but either way, he says no. And either way, it's a bad idea, but I can't persuade him. But grandma's got juice. And she says no is not an option. And done deal, he gets it. Now, not everybody does this well. This particular young man gets 6 consecutive doses. He's the poster child. Doesn't always go so smoothly. In fact, mostly it doesn't go so smoothly. But the family, the parental caregiver has these special attributes of relationship and love and persuasion and moral authority and leverage that we want to try to harness in this collaboration to make it go in a way that me and my white coat can't make it go. And that's the idea, whether we pull it off all the time or not. And I see that we're getting close to an hour. So before I show you more and show you data, maybe let's chat. Are there things that people wanted to ask before I keep blathering on? Let's see. Can you please explain what I meant by internal transformation? Sure. What I mean by internal transformation is the idea that young people or any patient get it and have insight and want to change themselves because they want to get better. And my point is, of course, that's what we'd eventually like to get to, but I don't think that's the way most young people achieve behavioral change and usually make changes at first because of pressures on them. So that's external motivation or external leverage or external transformation. And then if they eventually grow into doing it because they want to and they understand why, so much the better, but it's not required. And the classic parenting example of that is when you're teaching a 4-year-old to cross the street, you don't say, well, I want you to understand why you have to hold my hand. Well, if you don't want to hold my hand, you don't have to hold my hand. Go ahead, get hit by a truck. That'll learn you. Right? We say, no, you got to hold my hand and your behavior is going to change because I'm the mom and I said so. Now, I'm not saying that's going to be effective with a 19-year-old, the I said so thing. It illustrates the point of application of external leverage as a first step in behavior change. Sounds like MDFT. I don't know if a lot of you know about multidimensional family therapy. There are also other structural family therapies, brief strategic family therapy, and others. Sure, this shares some of those elements. The thing that's a little bit different, and I know in Connecticut, a very rich MDFT treatment implementation. And so kudos to those, hats off to those of you who know how to do that and are able to do that. But one of the things important to remember about that is that's a very intensive, scripted, manualized treatment that requires a ton of training and a ton of fidelity. And what I'm hoping, what we're trying to do, it's imbued with some of those same principles. And I've certainly at the feet of many of those masters in terms of learning some of these ideas. I'm trying to make this family treatment light so it's easier to scale. And so, again, that's why medicine is the focus in the beginning. That's why it's, let's just get the dose into them. That's why it's, what is it that you're going to do in your family already that you have as leverage before we do a whole lot of reorganizing of the family ecology. Not that those are bad goals, those are great goals, but they're downstream, harder to do goals. And I'm looking for lower hanging fruit earlier. At least that's what I'm hoping. I don't know if I'm right, but that's what I'm hoping. Is there a way we can get a copy of the PowerPoint presentation? Yes, of course. Is the family work solely focused on the adherence and support for MAT? Well, that's the thin edge of the wedge. If we can get that, by the way, I'm very happy and very grateful because that's hard enough to do. But to the extent that families will engage and want more and are willing to do more, sure, that's available. And we encourage, I will tell you that we've had trouble getting our families to go deeper. And I've been very satisfied if I can get them just to do a handful of these kinds of sessions and learn how to acquire the skills that will support medication adherence and OUD treatment retention. But sure, more would be better, for sure. A better way to describe to a family that they are enabling the client. I agree that the word is harsh and comes with a negative tone, but what are some ways to get around that word, but using a different phrase or explanation to the family that sounds more positive? No, that's a very important point because the concept is a real one. There are some families whose behaviors are reinforcing of the same old, same old. And so can we get them to do different? And I think that the way to do that is by building relationship over time and showing them illustrations and saying, so when this happened, how did it go? Could you have done something different? What were the pros and cons? How did you make that decision? And what would have happened, do you think, if you've done this other thing? But base it on having earned the currency of relationship engagement and having worked with them for some time. All right, so then let me keep on going. I wanted to illustrate another part of the intervention, part of this assertive outreach communication. And you can conceive of a number of ways of doing it. We've done a lot of group texting. And I'll tell you about that in a second, but that doesn't mean it couldn't be done with more sessions if people will come for sessions, or with phone calls, or with emails, or with carrier pigeon, or whatever in terms of communication. But we found that text is a pretty native communication style for the young adults and the adolescents, and that the parents are pretty able to manage it. And it's got the advantage of easy access, low barrier, and brevity. And so we do it without an app. There are HIPAA compliant, confidential texting apps, and those are good, and I recommend their use. Our concern was that anything that creates any teeny little barrier is just that, a barrier. And you wouldn't think it's a big deal, but having to download an app and enter a password and use a different ID is enough to sour it for some of our kids. We do, and the government folks may not like this, is we get people to sign consents up front saying, you're taking this risk of breach of confidentiality and you accept this HIPAA problem, and sign here. And if they agree, they agree. And if they don't, they don't. We're trying to be careful to keep lots of protected health information out of the text, but we acknowledge that there's a risk, and so be it. Is that scalable? I don't know. And in a big institution, I think the risk management people would freak out about it. So everybody's got to make their own choices. But this is what we've done so far. But you could do this. People would use the app. And the idea is that we get a group chat going that includes the young patient and the familial caregiver, or whoever the treatment significant other is, and the counseling team. And there's communication freely back and forth, initiated usually by the treatment team, but could be initiated by the youth or the parent asking a question or making a recommendation. And there's lots of deals. One is this simple goal of just monitoring, just keeping people in the loop. What's the appointment? What's the schedule? Did you get your shot? You're late a day. Hey, are you coming in tomorrow? Hey, great, catch them being good. Hey, you did a great job. Thank you. You gave us a negative urine. Hey, you've been abstinent for 30 days. Hey, you got your second shot. And that's really very helpful because it gives young people positive reinforcement that they say they feel they don't get from their parents, who are scolding them all the time, at least in their view. I'm not saying it's true, but that's their view. And it also helps us model that behavior for the family. They see us being overly gushing. At first, they think we're queer and silly and over the top, but they see it and they see it's effective, and that's helpful. But it also gives us an opportunity to keep them in the loop so they know. So we're not scolding behind the kid's back. Mom, I want you to know that your kid missed their shot for the third time, or missed IOP 3 days in a row. No, it's just, hey, Dave, are you coming in? We haven't seen you. And everybody can see that. It's an open discussion. So here are some examples of that. There's also, for surprising to an old guy like me, how much therapeutic content you can squeeze in to texts. I'm not saying it's a substitute for a 50-minute session where there's, real human interaction, but I'm surprised. And our therapists have gotten pretty good at trying to condense messages into little bits. So this is kind of a fun one. Hey, I'm getting kicked out because you told my mom I didn't leave a urine. So yeah, I'm going to have to stop the study or stop the program or stop the treatment. Or you can come leave a urine. I couldn't pee. What was I supposed to do? Wait for 2 hours till I could? I'm bleeping homeless now. I have to go to city now and live in an abandoned building. I'm still here. Come. Don't use this as an excuse to relapse. But, just being optimistic in the face of opposition, never giving up, trying to be encouraging. And you can get a lot in. And then later, all right, hey, I'm coming up to leave a urine. Great, we'd love to talk to you and blah, 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 blah. But it doesn't always go this well. But the note you can get content into these little bits. Here's an example, a clinical vignette that illustrates some application of parental leverage that I'm not sure is appropriate or not, but gives you a sense of family caretaker empowerment. We go out to the house to deliver a dose, and the young woman says, "Mom, you can't be in here while I'm getting the shot." Extended release naltrexone, you guys may know, is given as a gluteal muscle injection. So she's got to drop drawers, and that's embarrassing to her in front of her mother. And the therapist says, "No, ma'am, I think, this is a confidential medical procedure. Mom, I think it's best if we provide her privacy for the injection." And mom says, "Are you kidding me? I'm not leaving this room until I see the medicine go in." Now, is she being intrusive? Is she overdoing it? Is she being overbearing? Maybe yes, maybe no. That's for you to decide. But she's finding herself a role for being involved in the care in a way she never has before. She's feeling empowered that she can be involved and knows that she can influence the behavior. Over time, we can get her to stand down and stop being so intrusive and trust us to do our job, and she doesn't have to actually see it, and she can wait in the other room, and that would be fine. But it's just an illustration of this tension here that different people will have different, but one way or the other, we want to get them involved. And then, of course, we got to pick up the pieces with the young woman being mad at mom, and then I don't want to do this anymore. And so we got to work through those ramifications. But I think it is illustrative of the role. And I'm going to move ahead. Here's one. Can you stop calling my mother? I'm done. I don't want more shots. And just ignoring that with not taking no for an answer. Give us a call. Thanks for sticking with us. We'll see you tomorrow. And mostly that works. So let's more clinical puzzles. And think about how to work that through. We've got a 21-year-old young woman, but again, could be 18, could be 24, could be a young man, young woman, on an extended release MOUD, buprenorphine or naltrexone, doesn't matter. But they're late for the dose. They're missed the dose. They're living at home. We know that they've had some recent use, but they haven't maybe returned to full daily use with full physiological dependence. But they're on the verge, right? They're about to turn into a relapse. Emergency, they need this dose, and they're not particularly motivated to do it. So how do we work with this family? Do we call the cavalry? Do we push the panic button and behind their back immediately call the parents? Well, depends on what you think the urgency is and what you think the alternatives are. What's the potential cost of your therapeutic relationship with the young person? And what is winning this battle compared to the long game of the overall war? How do you balance that? And what's your clinical urgency? How much of an emergency is it? Or do you work with the patient exclusive of the parents, not involve the parents, but keep persuading the patient, but protecting the patient's confidentiality, who said, "No, don't rat on me and my mom, I'll get in too much trouble." Well, but you've already done some of that. How far are you willing to go and protect confidentiality and not involve parents if you're not making progress? Is it 1 day? Is it 2 days? Is it 3 days? Is it 1 week? Is it 2 weeks? Is how it's like you're watching a car crash in slow-mo. How long are you going to watch the slow-mo till you push the panic button? Will you operationalize that time frame by saying to the patient, "All right, I tell you what, you don't want me to talk to your mom. You don't want to get in trouble. I get that. I want you to know I don't agree necessarily with that approach. I think we can work with mom so that you won't get in trouble. But all right, that's the way you want to do it. I'll try it your way, but your way's got to work. So you get one more chance. Get the shot by X, Tuesday, next week, tomorrow, whatever. And if that doesn't work, we hope that works. I'm sure that'll work because you're so committed. I'm very pleased with that. But just in case it doesn't work, our backup plan is that we call mom. And under that circumstance, would you either at that future point or right now today say, okay, I won't call mom behind your back, but let's call her together. By the way, that's I think a very useful technique is to, let's do this together. I'll run interference for you. I'll try to use my status to not let mom cut your head off, and you get to frame it your way, and you get to earn honesty points, which is really good for you, and it's good practice for the communication skills, and you get to charge, and it's not behind your back. But I know if I just say, you go call your mom, let me know how it goes, that it'll never happen. So let's do it right now. Or do you say, I tell you what, I won't tell your mom today, but why don't we get the dose into you and you make that a priority? Let's think of that as an emergency. But once you do that, then we tell your mom together. And we're now calling, not that you've messed up, we're calling that you're a problem solver. It's from a position of strength now, not from a position of weakness. You were having trouble. Mom, I want you to know I'm being honest. I can't lie to you. I was struggling, but I've worked it out with my team and I got the shot and I just want to tell you about it. And I hope you'll be proud of me or something like that. Or do you send a group text, again, reminding everybody that the dose is late? What's everybody going to do about it? When are we going to get people in? When are we going to get the young person in to get the dose? And there's no right answer. I think all of these potential solutions have potential merit in different circumstances, depending on the particulars. But I just wanted to throw them out as a menu of different ways that we've tried to deal with this. And you could try one, you could try them in a sequence, you could try one, and if that doesn't work, then try the other. You could try one with one person and a different with the other person. But I, again, just wanted to kind of get you thinking a bit about the possibility of different strategies that each think about bringing family engagement in a collaboration together with the patient together to try to get the ball down the field. Let's just take some more questions. I've got some data that says that this kind of works in boutique research. And the bottom line is that in the randomized trial that we've done in the past, it works much better than treatment as usual, where 95% of the patients relapse over 6 months versus about 60% relapse with the intervention. Here are the two survival curves. On the left is the first trial we did with extended release naltrexone alone before there was extended release buprenorphine. On the right is when we introduced choice with extended release buprenorphine or extended release naltrexone. The curves look the same. The idea is almost everybody relapses in treatment as usual, but in the yours intervention, we do much better. That's the glass half full. Glass half empty is still 60% of people were relapsing over 6 months. It's a high severity, high chronicity population, and there's plenty of room for improvement. So that remains a question, what else can we add? Let me just show you some examples of some other ideas that are floating out there. One is integration into primary care. And this is an idea that is relatively well established in adults. And you may have heard the phrase the Massachusetts model that involves primary care prescribers in primary care medical practices using nurse care navigators to do case management and patient engagement so that people can get low barrier access to buprenorphine mostly or other MOUD. And that model in adults has been quite successful. Hasn't been used much yet in adolescents and in young adult youth care, youth serving specific instances, but some, and this is an emerging area of investigation. Dr. Sharon Levy up at Boston Children's has been a champion in doing this work. And the idea is that there are lots of pediatric and family practice medical primary care centers where they're seeing patients who have OUD. Maybe they know it, maybe they don't know it. And for many of those patients, going to specialty care is a big barrier. And so you say to the pediatricians and the family practice docs, you guys could prescribe buprenorphine, and they are apprehensive and scared. It's Halloween, so that's a very spooky thing for them to think about. And they say, well, I put out a shingle that says buprenorphine within. Next thing you know, I'm going to have a line twice around the block with heroin addicts. And that's not what I set out to do when I went to medical school, A, and B, that's going to chase all my other patients away. And C, I don't know how to do that anyway. What, are you crazy? And the response to that is, first of all, it's not that hard. We can teach you and hold your hand. Secondly, you will not have a line 3 times around the block. Our problem is that we can't get patients into treatment, not that there are too many and we're turning them away. And we're not asking you to take come one, come all from your entire region and be the regional buprenorphine heroin addiction expert. We're just saying, these are patients you already know, they're in your practice. We just want to help you identify yet another problem that patients you're already treating may have and that you can help them with. Just like when you figure out how to do extra stuff with diabetes or extra stuff with birth control or extra stuff with depression care. These are already your patients. Here's another tool. You either already know or don't know because it's a secret that they're suffering for this problem. Try to learn this extra tool. If you like it, that's great. If you don't like it, you can stop. And let's arrange in a hub and spoke model to support you through a specialty hub, specialty central hub mothership, specialty consultation and training, and we'll consult to you and we'll come out and hold your hand and we'll do the first couple of cases with you and we'll be available and give it a try. It won't be so bad. And then from there, the thin edge, once again, is medicine, because it's hard to teach doctors to do things anyway. But if you're going to teach them something, medicines are the easiest thing to teach them, and you teach them that at first. And then now they start to get interested in SUD. And then you start to say, hey, I wonder if any of the kids in your pediatric practice are using cannabis. Oh, I bet not. Well, I don't know, maybe. And of course, they all are. And so, well, what can you do about that? Oh, there's nothing I can do about that. Well, as long as you're now interested in learning a little bit about the techniques of SUD, now that you can prescribe a medicine for OUD, unfortunately, I don't have any medicine for cannabis use disorder. But if you want to learn more, or you want us to teach your social workers or nursing staff how to do more in terms of motivational interviewing and SBIRT and other kinds of fancy tricks, we know how to teach you to do that. What about that? And so again, it's nose of the camel into the tent, thin edge of the wedge, and trying to get people to be more sophisticated. And going upstream in the cascade, because of course we still want to utilize specialty care, but we know so many young people access other upstream touch points before they ever, if they ever, get to specialty care. And I see somebody asked about initiation in the ED, and that's exactly the same idea. People go to the ED with soft tissue infections, with suicidality, with hopefully non-lethal overdoses. But what happens? They get Narcan, they get a tired old Xerox of phone numbers that they can call, and most of those numbers are disconnected, and they don't take their insurance anyway, and they don't get a warm handoff, and they don't get full initiation. The idea that the questioner is implying is, what about initiating an actual MOUD intervention in the ED? Great idea. That's now been rolled out for adults in lots of places, but it's a relatively new idea for pediatric emergency departments and for developmentally specific outreach to young adults, but it's an idea whose time has come. Part of the problem is whereas it's a common occurrence in the adult ED, it's a relatively infrequent occurrence in the pediatric ED. Don't get me wrong, it happens way too much for my taste, but relative to other things that happen in the pediatric ED, it's relatively rare. And the way that we were able to move the needle on adult ED providers is by showing them how much of the time they were already spending with these patients in OD. So as long as you've got the patients and they're clogging up your EDs and they're dying in front of your eyes, you might as well do something more definitive about it. It's hard to make that same dramatic case to pediatric EDs, but it's still a good case, and it's still something that we need to do more of, for sure. So that's a good question. Yeah, your point is it's for adults, not necessarily youth. That's a newer idea, but it is a great idea. Do you require your clients to participate in ongoing clinical work during MAT, or do some of your clients only participate in MAT? That is a very vexing question. It's a great question. And there are a whole bunch of answers to that. If we have, as we do, some extra grant support to make this go, we have the luxury to be able to not have to rely on standard outpatient counseling models of SUD care to keep the lights on. Those of you who know something about the administrative side of the house know that most specialty community SUD providers pay salaries by butts in seats in groups. Not saying that's how it should be. I'm saying that's how it is. That helps a lot of people. It's a good model for treatment, but it's not the right model for everybody. But the problem is, if there are some people who need some other pathway, like low barrier MAT for people who are currently refusing other psychosocial interventions, even though we think they need them, it's very hard to support that model with standard fee-for-service reimbursement under the current public sector model. So that's a dilemma for clinicians and for administrations. Now, our hope is that if we can engage them with MAT and demonstrate partial success, that we will eventually get them in and be retained longer in psychosocial treatment, which is good both for their clinical outcomes and for our revenue models, but that isn't assured. So every clinic, every program has to kind of address that way. The more flexible you can be, the more patient-centered you can be, the better, but it's easier for me to say, and you still got to keep the lights on and pay the bills. And that's an unfortunate feature of the way we've designed our system currently. There's also the question of, what if medicine alone isn't working? And so what do you do to push the issue of you need extra dose of counseling, an extra dose of therapy, an extra dose of group, an extra dose of NA, an extra dose of mental health, an extra dose of other stuff that you're stubbornly resisting or declining? Well, we keep on being encouraging. And I guess there does come a point where you say, I'm not helping you adequately. Maybe there's a different place that'll help you better. What we aspire to is never giving up on anybody, right? And keeping going and continuing to try to reel them in by showing them through engagement in at least some service that other services might help. But again, having the luxury and the flexibility to do that is difficult. And then everybody's got a treatment milieu. So part of the problem is if you do it for one patient, then everybody else says, well, he doesn't have to go to group. Why don't I have to go to group? And then you got a big problem with your overall milieu. So these are not easy answers. If you ask me, what does the research show? I got to tell you, nobody really knows. There has not been much investigation of alternative delivery models for care. So we can't answer that question with science yet. And that's too bad. And that work really needs to be done. And not only, we don't even know it for adults. And we know this much for adults, but we know almost nothing for young adults. I will tell you, there is one good research study that gives us a hint that tells us that it is possible to demand too much of young patients so that they'll not engage at all, and that there is probably a sweet spot in between, say between asking them to have to come 4 times a week or to come every day in order to get medicine, versus saying, here's a month's worth of medicine and 4 refills and have a nice life, which is obviously not enough. Somewhere in between is some sweet spot that they're willing to do, and is enough dose to support them, but we haven't really identified where that sweet spot is. Those of you who are doing work with young people, either with OUD or other SUDs or mental health problems or whatever it is, please keep doing it. We appreciate your being part of the solution. There aren't enough of us. The kids need us, their families need us. So thanks for your contributions.